Welcome back to the deep dive. Today we're opening up a document that, quite frankly, strikes a lot of fear into the hearts of many residents and even seasoned practitioners out there.
Oh, absolutely.
We are tackling the beast that is the 2025 edition of the EAU guidelines on chronic pelvic pain.
Yeah, it's a massive topic. And you are right about that fear factor. I mean, for a lot of urologists, this is the classic heart sink condition.
Heart sink, yeah.
You see chronic pelvic pain on the chart outside the door, and you just know you're in for a really difficult consultation. The pathology is often completely invisible. The patients are suffering immensely. And the traditional, the find it and fix it surgical model that we urologists absolutely love, it just doesn't work well here.
Right, we can't just cut it out. But we have a very specific mission today. We aren't just going to sort of wallow in the complexity of it all. We are going to conduct a comprehensive, high-yield review of these guidelines specifically tailored for you, the urologist preparing for your board exams. We know who is listening right now. You're the learner. You're busy. You need structure. You really need to know what separates a clinical habit from a guideline fact that will actually get you points on the test.
And that is the key distinction right there. There is a lot of, well, let's call it voodoo in pelvic pain management in the real world.
So much voodoo.
Right. Empirical antibiotics, random surgeries, just endless investigations that lead absolutely nowhere. The board exam wants you to know the evidence-based pathway. And the 2025 EAU guideline is the absolute gold standard for that pathway.
If you answer based on what you saw, like your senior partner do in clinic 10 years ago, you might fail.
You probably will fail. But if you answer based on this document, you pass.
Okay, so consider this your audio study guide. We are going to break it down section by section, ensuring we hit every high-yield point. But before we get into the weeds of, taxonomy and drug dosages, we really need to set the stage. What is the core paradigm shift in this 2025 edition? Because it really feels like the whole philosophy of pain has changed over the last decade.
It has, and it's a profound shift. The fundamental concept you need to grasp, the headline of the entire guideline, is viewing chronic pelvic pain, or CPP, not just as a symptom of something else, but often as a disease process in itself.
Pain as a disease. That's a phrase the guidelines use a lot, but it sounds a bit abstract. What does it actually mean for the clinicians sitting across from a patient?
It means that in many of these patients, we have to stop looking for the peripheral generator.
Like the active infection.
Exactly. The infection, the stone, the stricture. Those things might have started the process years ago. Maybe they had a really bad UTI in, say, 2018. But the bacteria are long dead. The tissue has completely healed. Yet the pain remains.
And why is that?
Because the pathology is no longer in the bladder or the prostate. The pathology is in the processing of the signal. The central nervous system has fundamentally changed. The pain is the pathology.
Which explains why the guidelines are so aggressive about moving away from those old itis terms.
Precisely. You will hear us say this a dozen times today. Do not use the term prostatitis unless you have proven infection.
Right.
Do not use interstitial cystitis as a catch-all bucket. The guidelines are moving entirely to a descriptive phenotypic model. If you use an itis suffix, you are implying inflammation. And if you imply inflammation, you are tempted to prescribe anti-inflammatories or antibiotics.
And if there is no inflammation, those drugs are just wrong.
It's a linguistic trap that leads directly to a treatment error. And the boards will test you on that trap.
And this leads us right into the biopsychosocial model. This is another buzzword that comes up on the written boards all the time.
Right. And it's not just a buzzword. It's the mandatory framework for management. You cannot treat these patients with a scalpel alone. You need to address the biological, the nerves, the muscles, the organs. You need to address the psychological, the anxiety, the depression, the catastrophic thinking, and the social, the impact on their work, their relationships, and their sex life.
If you miss one leg of that stool,
the patient and your treatment plan falls over. The guidelines are absolutely explicit here. A monomodal approach where you just treat the organ is destined to fail.
And just a quick note on the source material itself, the panel that actually wrote this thing, it's not just a room full of urologists, is it?
No, and that's really important for understanding the weight of these recommendations. The panel includes urologists, yes, including neurourology and sexology experts, but also pain medicine specialists, Gynecologists, psychologists, gastroenterologists, physiotherapists, and even patient advocates.
That's a huge mix.
It is a truly multidisciplinary document because the condition completely ignores our neat little specialty boundaries. The pelvis is a very crowded space. The nerves down there don't care if you're a urologist or a gynecologist.
Okay, let's get into the meat of it. Section 1. Taxonomy, definitions, and classification. This is the bedrock. If you get the definitions wrong, you get the diagnosis wrong, and you definitely get the board question wrong.
Yes. The most critical distinction the board exam will test you on is the difference between chronic secondary pelvic pain and chronic primary pelvic pain syndrome.
Let's unpack that. Start with secondary.
Okay, chronic secondary pelvic pain is pain associated with a specific, well-defined disease. This is what we're used to dealing with. If you have a patient with a confirmed urinary tract infection or bladder tumor or a mesh complication or endometriosis that is visible and active, that is secondary pelvic pain.
So in those cases, the pain is just a symptom.
Correct. It is a symptom of a disease. You treat the disease, you remove the tumor, you treat the infection, you excise the mesh, and the pain resolves. That is not a pain syndrome in the sense we were discussing today. That is just standard urology.
Okay, so secondary equals known cause. And then we have the star of the show, chronic primary pelvic pain syndrome, or CPPS.
This is the focus. This is defined as the occurrence of chronic pain when there is no proven infection or other obvious local pathology that may account for the pain. It's a diagnosis of exclusion.
You've looked for the cancer, you've looked for the bacteria, and you found nothing.
Exactly. But the patient is still hurting.
And there is a specific time frame here. For the board exam, what is the magic number?
3 months. The definition requires pain to be chronic or persistent for at least 3 months. This aligns perfectly with the ICD-11 definitions.
So if a patient comes in with 6 weeks of scrotal pain and I diagnose them with chronic primary scrotal pain syndrome, I am wrong.
You are 100% wrong. That is acute or subacute pain. You manage that differently, perhaps with more rest, NSAIDs, watchful waiting. To label it a chronic syndrome, you need to cross that 3-month threshold.
That timeline is a hard cutoff.
It is a hard cutoff in the guidelines to prevent premature labeling of patients.
Now let's dive into the forbidden words. We touched on this, but let's be really specific because the board exam often has negative marking or distractor answers using these exact terms. First up, the term chronic prostatitis.
The guidelines explicitly state that prostatitis is an inappropriate term in the absence of infection. Historically, we called everything chronic prostatitis or chronic pelvic pain syndrome, CPPS. The new terminology completely splits that.
How so?
If there is an infection, it's bacterial prostatitis, which falls under secondary pain. If there is no infection, it is primary prostate pain syndrome, or PPPS.
PPPS, primary prostate pain syndrome. Got it. And what about prostadenia?
Out. Gone. Do not use it. The expert panel explicitly recommends against it. It's an archaic term that implies a mechanism we now know is simply incorrect.
Because it suggests the pain is purely of the prostate.
Right, which completely ignores the central sensitization aspect we just talked about.
What about the bladder? We all learned interstitial cystitis, or IC. It's in literally all the old textbooks.
That is being replaced by primary bladder pain syndrome, or PBPS. You might see bladder pain syndrome or BPS, but the word primary is the key addition to distinguish it from secondary causes. The terms interstitial cystitis or painful bladder syndrome are no longer recommended.
Why get rid of interstitial cystitis, though?
Because it implies a specific inflammation of the interstitium, which is often not present at all. PBPS is a clinical description, not a histological one.
So on the oral boards, if I say, I suspect interstitial cystitis, the examiner might grimace.
They definitely might. Better to say, I suspect primary bladder pain syndrome. It shows you are current with the 2025 literature.
And what are the specific diagnostic criteria for PPPS? Because it's not just, hey, my bladder hurts.
No, you need rigor here for the exam.
Yeah.
It's persistent or recurrent pain perceived in the urinary bladder region, accompanied by at least one other symptom.
Like what?
Like pain worsening with bladder filling or urinary frequency or nocturia. And of course, the absolute requirement is the exclusion of confusable diseases.
Confusable diseases meaning things like carcinoma in situ.
Exactly. You cannot diagnose PBPS until you've proven it's not cancer. If you diagnose PBPS and you missed a CIS, you have failed the exam and you failed the patient.
We also have primary scrotal pain syndrome, primary testicular, primary epididymal. It seems like there's a syndrome for every anatomical landmark down there.
There is. But this brings us to a really crucial concept in the guidelines, the perceived caveat. This is intellectually the hardest part for patients to accept, and sometimes for doctors too.
The perceived caveat, explain that.
The definition says pain is defined by where it is perceived by the patient. So a patient comes in and says, my testicle hurts. That is primary testicular pain syndrome. However, the guidelines warn us that the site of perception may not match the actual source of the pain.
Because of central sensitization and referred pain?
Exactly. The brain maps the pain to the testicle, but the actual pathology might be in the pelvic floor muscles or the spine or the brain itself.
I think the guidelines use a really good analogy here.
The check engine light. It's like the check engine light in your car. The light is glowing on the dashboard, but the problem is actually under the hood. The testicle is just the dashboard.
This is why knowing the definition is so incredibly important. Just because you diagnose primary testicular pain syndrome doesn't mean the problem is in the testicle. It just means the patient feels it there.
Which is exactly why purely organ-centric treatments, like removing the testicle, often fail so miserably. You remove the dashboard light, the testicle, but the engine, the nervous system, is still broken.
And then this patient wakes up from surgery with a phantom testicle that still hurts.
That is a clinical disaster, and it happens all the time.
Let's talk about phenotyping. Why do we bother classifying these patients so strictly? Why not just call it all pelvic pain and throw the kitchen sink at it?
Because pelvic pain is way too broad to treat effectively. It's just a massive bucket. We phenotype to guide our treatment and our research. If you treat everyone with antibiotics, you only help the 5% with an actual infection. If you treat everyone with amitriptyline, you only help the neuropathic phenotype. We need precision. And the guidelines highlight the U-Pint-T system for this.
U-Pint. This is a classic mnemonic. Walk us through it. The board loves this because it's a perfectly structured list.
It's perfect for a multiple choice question. It was developed to classify the clinical phenotype. U is for urinary symptoms, so frequency, urgency, flow issues.
Okay.
P is for psychosocial. That covers anxiety, depression, catastrophizing, poor coping skills.
Got it.
O is for organ-specific. Is the prostate tender on exam? Is the bladder tender? Are there leukocytes in the expressed prostatic fluid?
Right.
I is for infection. Do they have a history of infection, even if they're clear right now? Or do they have an actual active, localized infection that's contributing?
Which would normally push them to secondary, but history of infection is a clue.
Exactly. Then N is for neurologic or systemic. Do they have fibromyalgia, irritable bowel syndrome, or other regional pain syndromes? And finally, T is for tenderness and the skeletal muscles, specifically pelvic floor trigger points.
And the guidelines also mention a modification to this U-Point system, right?
Yes, the Megarry modification, which adds a sexual dysfunction domain.
Yeah.
So you might see it written as UPSS. Sexual dysfunction is a huge issue in this population, erectile dysfunction, pain with ejaculation. It absolutely needs to be addressed.
The beauty of UPS is that it directly dictates the therapy. It's an algorithm.
Exactly. If they have the T domain positive for tenderness, you send them to physio. If they have the P domain positive for psychosocial, you refer for psychology or CBT. If they have U for urinary, maybe you use an alpha blocker. You treat the specific domains that are positive. Studies show that the more domains a patient has positive, the worse their quality of life. And multimodal therapy based on UPS significantly improves outcomes compared to just trying one therapy for everyone.
There's also mechanism-based phenotyping. Can you give us an example of that for the boards?
The classic example is in primary bladder pain syndrome. We distinguish between patients who have Hunner's lesions on cystoscopy and those who don't.
Why is that specific distinction so important to make?
Because if they have Hunner's lesions, which the new classification calls type 3C, you treat the lesion. You resect it with a TUR or you laser it. The evidence is very strong that this works.
Right.
But if they don't have the lesion, so they are type 3A or 3B, surgery usually doesn't help at all and can actually cause harm.
So that is a phenotype that completely dictates a surgical intervention. You cannot treat type 3C and type 3A the same way.
You absolutely cannot.
Okay, let's move on to section 2, epidemiology, etiology, and pathophysiology. The why. We've talked about pain as a disease. Let's really dig into central sensitization. This concept is vital for answering those why aren't they getting better questions.
This is the engine that keeps the condition running. Imagine a patient gets a severe bacterial prostatitis. That's a massive peripheral stimulus. It hurts. The nociceptors are firing constantly. In most men, the antibiotics kill the bacteria, the inflammation settles down, and the pain stops entirely. But in CPPS, that initial heavy bombardment of pain signals fundamentally changes the central nervous system.
That's neuroplasticity. The nervous system actually learns the pain.
Yes, exactly. The dorsal horn of the spinal cord physically changes. The neurons become hyperexcitable, they lower their firing threshold. This is a process called wind-up.
Wind up, so the system is primed.
Right. So now, even normal, non-painful signals, like just having a full bladder or sitting down on a hard chair, are interpreted by the brain as severe pain. The software of the pain system has been corrupted.
And this leads to a neuropathic pain state.
Correct. It becomes entirely self-perpetuating. The peripheral organ might actually be completely healed and look normal on a biopsy, but the alarm system is still ringing at full volume. This helps explain why anti-inflammatories so often fail. There is literally no inflammation left to treat. You need neuromodulators.
This brings us to what I call the psychological trap. I think a lot of patients feel incredibly dismissed when a doctor brings up psychology. They hear, oh, the doctor thinks it's all in my head.
And that is a real tragedy in clinical practice. The guidelines are extremely clear on this point. There is zero evidence that distress generates the pain. The pain is not imaginary. It is not all in their head in the sense of being made up or faked. The pain is real, measurable physiology.
So how do we explain the psychological connection to the patient then? And more importantly, how do we explain it to the board examiner?
We explained that while stress didn't create the pain out of nowhere, factors like anxiety, depression, and catastrophic thinking act as massive amplifiers. They turn the volume knob way up on that central sensitization. If the brain is already on high alert due to anxiety, it interprets every single minor signal from the pelvis as a major threat.
Catastrophic thinking. That's a very specific term used in the text, isn't it?
It is. It's a cognitive distortion. It's when a patient fixates on the worst possible outcome. They think, this pain means I have undiagnosed cancer, or this pain means I'll never be able to have sex again, or this pain is going to completely ruin my life.
And that thought pattern actually makes the pain worse physically.
Yes. That thought pattern physically changes the way the brain processes the descending pain pathways. It creates a vicious feedback loop that chemically sustains the pain state.
The guidelines quote some pretty heavy numbers regarding how common this all is.
Yes, a UK study showed a 14.8% prevalence of chronic pelvic pain in women over 25. That is incredibly common. It's more common than asthma or migraine in some cohorts.
And regarding risk factors, there is a very serious one we need to screen for. This is something that is so often missed in a busy 10-minute clinic slot.
History of sexual or physical abuse. The guidelines are adamant here. You must screen for this. The data clearly shows that men who reported sexual or physical abuse had significantly increased odds of having symptoms suggestive of CPPS. For women, the link is also incredibly strong.
It's a major risk factor for the development of that sensitized nervous system.
It is. You cannot treat the whole patient if you just completely ignore that trauma history. It changes your whole approach to physical exams and therapy.
Let's look at specific organ mechanisms briefly before we move to diagnosis. The prostate.
Again, the evidence strongly argues against acute inflammation being the driver in the chronic phase. Histological studies of men with what we used to call chronic prostatitis often show no more inflammation than men without any pain at all. It points heavily to a neuropathic origin. It's a nerve problem, not an infection problem.
What about the bladder?
The bladder is heterogeneous. It's a mix. Some patients have that inflammatory phenotype, the Hunter's lesions we mentioned. Those patients typically have significantly reduced bladder capacity and severe urgency. But others have purely functional or sensory issues with a completely normal-looking bladder mucosa. This is exactly why the guidelines are so big on phenotyping PBPS. It's highly likely that PBPS is actually 2 or 3 different diseases that are currently forced to share one name.
And the scrotum.
Nerves in the spermatic cord play the key role there. It's often a form of neuritis or nerve entrapment. The ilioinguinal or genitofemoral nerves can be deeply involved.
Okay, let's move to section 3. Diagnostic evaluation, the algorithm. This is the highly practical what do I do Monday morning in clinic section.
Right. The first phase is the rule-out phase. The guidelines give a Level 2A recommendation that a comprehensive history and physical exam are mandatory.
That seems pretty obvious, but what are we specifically trying to achieve or prove?
We're trying to aggressively exclude the specific diseases. We're hunting for the cancer, the active infection, the distal ureteral stone. If we find those things, the patient leaves the primary pain algorithm entirely and goes to the oncology or stone algorithm.
Yeah.
You are effectively clearing the deck before you commit to diagnosing the syndrome.
And again, we are checking the calendar.
The 3-month rule. If it hasn't been 3 months of continuous or recurrent symptoms, you cannot diagnose the syndrome. You simply treat them symptomatically and wait to see how they evolve.
Let's talk about the physical exam. There is a very specific practical pearl here about how to examine these patients. If you describe a standard aggressive exam on the oral board, you might get dinged.
The single-digit rule.
Explain that for the listeners.
The guideline suggests that for the clinical pelvic examination, whether that's vaginal or rectal, you should use a single digit.
Why only one?
Because these patients are often extremely hyperalgesic, they have severe allodynia, their pelvic floor muscles are locked in spasm. If you go in with a standard, vigorous bimanual exam, inserting 2 fingers and pressing down hard on the abdomen, you will cause severe pain. The patient will immediately guard, their muscles will clamp down further, and you will learn absolutely nothing from the exam.
So a gentle single-digit exam allows you to assess the muscles without overwhelming the patient's nervous system.
Exactly. It's about building trust and getting an accurate assessment of muscle tone.
And what exactly are we feeling for during this gentle exam?
We are feeling for masses, obviously, to rule out secondary causes.
Okay.
But crucially, we are looking for tenderness and trigger points specifically in the pelvic floor muscles. Does pressing on the levator ani or the obturator internus reproduce their specific pain? That is the T domain in U.2.
And for men, doing the digital rectal exam.
We check the prostate. Does palpation convincingly reproduce the exact symptoms they came in for? Well, we also meticulously check the muscles around the prostate.
Yeah.
Often the patient will say, that's my prostate hurting, when you are actually just pressing on the levator muscle right next to the prostate. You need to distinguish between organ pain and muscle pain.
The guideline also talks about mapping cutaneous allodynia.
This is a fantastic bedside test for central sensitization. You test the skin sensation in the specific dermatomes, T11 to L1 for the lower abdomen, S3 for the perineum. You can use a cotton whisk for light touch or a pinprick.
And what's a positive result?
If light touch feels painful, which is allodynia, or a pinprick feels wildly exaggerated, which is hyperalgesia, that tells you immediately that the central nervous system is involved. The volume is turned up. It confirms the neurologic or systemic phenotype.
Questionnaires, are they mandatory? Because nobody likes doing paperwork.
Strong recommendation. You should absolutely use validated symptom scoring instruments, the NIH-CPSI for prostate pain, the BPIC-SS for bladder pain.
Why? Is it just to collect data for research?
No, it's for baseline assessment and tracking follow-up. Pain is highly subjective. You really need a number to know if your multimodal treatment is actually working. The patient saying, I feel a bit better, is nowhere near as useful as seeing their score drop from a 25 to a 15. It also standardizes the interaction and makes sure you don't miss domains.
Now let's get into the specific diagnostic tests. What to order and, maybe more importantly for the boards, what to skip. Urine.
Dipstick and culture for everyone. You must rigorously rule out infection. And urine cytology, if they're in any kind of risk group like smokers or older age, to rule out CIS. This is non-negotiable.
PSA.
The text doesn't explicitly mandate checking a PSA specifically for the pain diagnosis, but it is part of the excluding specific disease phase. You check it to ensure you aren't missing prostate cancer in the appropriate age group. But remember, an elevated PSA does not diagnose prostatitis in the absence of bacteria. It just means the prostate is unhappy or inflamed.
Imaging. This is a big one. It feels like a Choosing Wisely campaign moment. Scrotal ultrasound.
This is a massive high-yield point for the exam. The guideline states with Level 2B evidence that ultrasound of scrotal contents does not aid in the diagnosis or treatment of scrotal pain.
Wait, really? So if the physical exam is normal, you feel 2 normal testicles, no masses, you do not order the ultrasound?
Correct. Do not order it. It rarely changes management. What it usually does is find completely benign cysts, mild varicosities, or epididymal cysts that are purely incidental.
But once the patient reads that on the radiology report,
They fixate on it entirely. They come back and say, doctor, treat my cyst. My cyst is causing the pain. It drives unnecessary anxiety and often leads to completely unnecessary surgery that won't fix the pain. Trust your hands on the physical exam.
laparoscopy.
Strong recommendation to refer to a gynecologist for laparoscopy if a gynecological cause is suspected. It is very well tolerated and is the absolute gold standard for diagnosing endometriosis. Pelvic ultrasound very often misses superficial endometriosis. If a woman has cyclic pain and negative imaging, she needs a lap.
Cystoscopy. Now, I've heard lots of debates about this. Do we cysto everyone with pelvic pain?
The guideline is actually quite aggressive here. It gives a strong recommendation to perform cystoscopy in patients with bladder pain, specifically to subtype and phenotype them.
But not just any quick office cystoscopy, right?
Right. The technique matters immensely. They specify general anesthetic rigid cystoscopy with hydrodistension and biopsy.
Why under general anesthesia?
because you simply cannot get a true adequate hydrodistension in an awake patient. It is way too painful for them. You need to stretch the bladder to maximum capacity to see the glomerulations or the waterfall bleeding that might indicate pathology, or to properly identify Hunner's lesions, which can sometimes be quite subtle.
And if you see a lesion, you have to treat it right then.
Exactly. You need to biopsy or resect it, which requires a rigid scope and a patient who isn't moving.
That's a really key takeaway. An office flexible cystoscopy might not be enough to rule out the PPPS phenotypes. If you just do a flex cysto and write normal in the chart, you might be completely missing a type 3C PPPS.
Exactly. For the boards, the full diagnostic workup for PBPS includes hydrodistension under anesthesia. Don't fall for the flexible cystoscopy distractor answer.
Finally, in this section, psychological assessment.
Strong recommendation. You must assess for pain-related fear, anxiety, and depression. And there is a very specific question the guidelines suggest asking every patient. What do you think is the cause of your pain?
That's a really powerful, open-ended question.
It reveals the catastrophic thinking instantly. If they say, I know it's a hidden cancer, but you've already definitively ruled out cancer, you know you have a major psychological target to treat that specific fear. If they say, I think it's a persistent infection, but all cultures are negative, you have an educational target. You have to correct that false belief.
Okay, so we've diagnosed them, we've phenotyped them using UP-on-T, now we actually have to treat them. Section 4, management. Let's start with conservative and physical therapy.
The overarching philosophy of management here is holistic. Single interventions rarely work. If you are a doctor who just wants to write a prescription and leave the room, you will fail with these patients. You need a multimodal approach.
And it starts with patient education.
Legitimization.
Yeah.
You have to look the patient in the eye and tell them, I believe you. This is a real physical condition. Explain the pain as a disease concept to them early on. That validation alone is highly therapeutic. It lowers their anxiety, which in turn lowers the central sensitization.
Physical therapy, is this really a first-line treatment?
Absolutely first line, especially for the myofascial phenotype. High-tone dysfunction, which is an overactive spasming pelvic floor, is incredibly common in these patients. They are holding all their stress and tension in their pelvis. It's exactly like grinding your teeth at night, but in your pelvic floor muscles.
And what does the physio actually do? Because I think a lot of urologists just write a script for PT and assume it means Kegel exercises.
No. In fact, Kegels, which are strengthening exercises, might make the pain significantly worse if the muscle is already tight and exhausted. Imagine a bicep that is cramped in a severe spasm. You don't do bicep curls to fix it. You stretch it and massage it out.
So what's the correct order for the PT?
The treatment is myofascial physical therapy, trigger point release, relaxation techniques, paradoxical relaxation, and Thiel massage.
Thiel massage, that's a very specific transvaginal or transrectal massage technique, isn't it?
Yes, and the guidelines specifically cite a study showing that myofascial therapy was superior to global therapeutic massage for bladder pain. So it absolutely needs to be specialized pelvic floor physio. Just sending them to a generic sports physio for core strengthening is the wrong answer for the boards and the patient.
Biofeedback.
Strong recommendation as an adjuvant to exercises, especially for anal pain or an overactive floor. It helps the patient visually understand their muscle tension so they can literally learn to drop it. They watch a screen, they see the lines spike up when they clench, and they learn the mind-body connection to make that line go down.
Diet. Patients love to ask about diet. Should I stop drinking coffee, stop eating spicy food, cut out citrus?
The evidence here is actually classified as weak. Dietary restriction alone doesn't produce significant durable relief across the board. Some patients definitely have specific triggers, but many don't.
So what's the recommendation?
The guideline gives a weak recommendation to involve a dietitian. So it's worth a try to identify individual triggers, but don't promise them a cure through diet. And more importantly, don't make their life miserable with a massively restrictive diet if it's not actually helping their pain scores.
Psychological therapy. We mentioned CBT earlier.
Cognitive behavioral therapy is highly effective. It improves quality of life and daily function. It helps patients cope with the reality of chronic pain. There is a strong recommendation to refer patients with significant distress to a psychologist.
Does it actually lower the pain score, though?
Note this for the exam. The studies show it improves quality of life significantly. Even if the raw pain intensity score doesn't drop all the way to 0, it changes the impact of the pain on their life. They can go back to work even if they still have a 2 out of 10 ache.
Section 5, pharmacological management. This is the heavy board stuff, the drugs. Let's start with the basics. NSAIDs like ibuprofen or naproxen.
We use them like candy in urology. But for chronic primary pelvic pain. The evidence is weak to non-existent.
That's really surprising to a lot of people. Why is that?
Because the mechanism is central, not peripheral inflammation. NSAIDs work entirely on peripheral inflammation by blocking prostaglandins. If the pain is centrally mediated windup, the NSAIDs completely miss the target. The guideline says use them only if an active inflammatory process is clearly suspected, like dysmenorrhea. For general CPPS, they are not recommended as an effective monotherapy.
Neuropathic agents, gabapentin, pregabalin.
These make total sense mechanistically. They directly target the central sensitization. You titrate them to effect. They are a staple of pain management here. They actively dampen that windup in the spinal cord. The main limiting factor is the side effects, primarily drowsiness and dizziness.
Now, let's look at specific recommendations for primary bladder pain syndrome, PBPS. What is the classic first-line oral agent?
Amitriptyline.
A tricyclic antidepressant.
Yes, but importantly, you use it at subtherapeutic doses for depression. You prescribe maybe 10 to 25 milligrams at night, not the 150 milligrams a psychiatrist would use. At low doses, it has strong neuromodulating and pain-relieving effects. It is a strong recommendation. It stabilizes the mast cells and calms the hyperactive nerves.
Pentosan polysulfate, also known as Elmaron.
Also a strong recommendation for PBPS. It's believed to help repair the glycosaminoglycan, or gauge, layer of the bladder. That's the waterproof coating. If that coating is defective, the potassium in the urine constantly irritates the submucosal nerves. Pentosan theoretically repairs that coating.
Antihistamines.
They are mentioned, drugs like hydroxyzine or cimetidine, but the evidence varies quite a bit. They're often used, especially if the patient has a strong history of systemic allergies or asthma, which might suggest a mast cell activation issue driving the bladder pain. But amitriptyline and pentosan are really the headliners you need to know.
Corticosteroids.
Strong recommendation against long-term oral use. Do not put these patients on chronic daily prednisone. The systemic side effects, diabetes, osteoporosis, weight gain are severe, and the long-term pain benefit just isn't there.
Intravesical installations.
Putting drugs like hyaluronic acid, chondroitin sulfate, or lidocaine directly into the bladder via catheter. These carry weak recommendations, but they are very valid low-risk options to try before you jump to irreversible surgery. They aim to coat and soothe the bladder lining directly.
Moving over to primary prostate pain syndrome, PPPS, antibiotics. This is the trap.
This is the ultimate board exam trap. Antibiotics are only recommended if an infection is proven by culture. That means NIH consensus types 1 and 2 only.
But in real-world practice, many patients swear they feel better on a course of Cipro.
They do, and that confuses doctors. They feel better often because antibiotics like macrolides or tetracyclines and even fluoroquinolones have potent intrinsic anti-inflammatory properties completely separate from their antimicrobial action. But the guideline explicitly discourages long-term empirical antibiotics.
Because of the collateral damage.
Exactly. It leads to severe antibiotic resistance and destroys the gut microbiome. You're using a sledgehammer to crack a nut and you're breaking the wrong nut.
Alpha blockers for prostate pain.
Often used, but the evidence is only mixed to moderate. They really only help if there's a demonstrable voiding issue. That's the U domain in U point. For pure pain without voiding symptoms, they aren't a magic bullet. They relax the bladder neck, which might help if the theory of intraprostatic urinary reflux is causing the irritation.
The opioid warning. We have to talk about this.
This is a strong recommendation in the text. Opioids should only be prescribed following a full multidisciplinary assessment, and only after all other conservative treatments have completely failed.
So a solo urologist shouldn't just be handing out monthly oxycodone scripts to manage the clinic flow?
Absolutely not. There is a very high risk of dependency. You must involve a dedicated pain specialist. Furthermore, opioids can actually cause a phenomenon called opioid-induced hyperalgesia, which makes the entire pain system even more sensitive over time. It's the exact opposite of what you want to achieve.
Cannabinoids. Medical marijuana is legal in many places now.
Systematic reviews do show general benefits for chronic pain, but the evidence specific to pelvic pain is still much less robust. It's an option on the table, but it is not a first-line strong recommendation yet, according to the 2025 text.
Let's move to Section 6, Interventional and Surgical Management. This is when all the conservative measures fail. Let's talk neuromodulation first.
TENS, which is transcutaneous electrical nerve stimulation, is non-invasive and very safe. Good for dysmenorrhea and general CPPS.
What about sacral neuromodulation, SNS, like Interstim?
It only gets a weak recommendation for pain. It's fantastic for overactive bladder with severe urgency and frequency, but for pure pain, the results are much less predictable. The pain might improve, or it might just move to a different location, or it might stay exactly the same. Do not ever promise a patient a cure for their pain with an SNS device.
Posterior tibial nerve stimulation, PTNS.
Weak recommendation, specifically noted for chronic anal pain.
Injections. Let's talk about Botox.
There are two main uses for Botox here. First, injecting Botox directly into the pelvic floor muscles to treat severe spasm. The trial results are mixed. It reliably lowers the resting muscle pressure, but it doesn't always reliably lower the subjective pain scores.
And the second use?
Botox injected into the bladder muscle.
For PBPS.
Yes. Botox plus hydrodistension is a strong recommendation for PBPS if standard installations fail. It significantly helps with the urgency and frequency, which often drives the pain cycle.
Surgery. The absolute last resort.
The general overarching rule here is you only undertake ablative or reconstructive surgery as a very last resort, and it must be done by highly experienced surgeons in a multidisciplinary setting.
Because you can't undo it.
Surgery is irreversible. If you remove an organ and the pain stays because the pain was central, you have created a permanent, terrible problem.
Scrotal pain surgery. This is an absolute minefield on the exam and in real life.
Microsurgical denervation of the spermatic cord.
Is it actually recommended?
It has a weak recommendation, but it is considered effective in one very specific group of patients. Patients where a spermatic cord block temporarily but completely relieve their pain.
So the nerve block in the clinic is the required predictor.
Yes, no successful block, no surgery. You inject lidocaine into the cord in the clinic. If the patient says, wow, my pain is 100% gone for the next 4 hours, then surgically cutting those exact nerves might actually work. If the block does nothing, the pain is central or originating elsewhere, and denervation surgery will fail.
Epididymectomy. Removing the epididymis.
Very poor evidence, especially if the ultrasound is completely normal. Do not just start whittling away at the scrotum hoping to find the pain. It usually makes it worse.
Vasectomy reversal.
There is good evidence, level 2B, specifically for post-vasectomy pain syndrome. If the pain started directly after a vasectomy and is due to congestive epididymitis, reversing it to relieve that back pressure is a logical and often very effective step.
And for the bladder, TUR or laser ablation.
Strong recommendation only for PBPS type 3C. That is the Hunner's lesions. If you see the classic lesion, you treat it. If there is no lesion, do not arbitrarily resect or burn normal-looking mucosa.
And finally, a quick point on inguinal hernia repair.
It's an interesting nugget in the text. Laparoscopic hernia repair actually has a higher risk of causing chronic scrotal pain than open repair. That's level 1B evidence. It's definitely something to keep in mind when consenting patients, especially those who already have pre-existing vague groin pain.
That brings us to the end of the evidence. Let's head to the outro and recap the board exam golden rules for our listeners.
All right, let's summarize the absolute must-knows. Rule 1. Rule out secondary pain first. Hunt down the infection and the cancer.
Rule 2. Terminology.
It's not prostatitis without bacteria. It's primary prostate pain syndrome. Stop using the itis.
Rule 3. Timeline.
You need a 3-month duration of symptoms for the official diagnosis.
Rule 4. Phenotype.
Use the UPOINT system. Categorize the symptoms and treat the specific domains. Physio for T, psych for P.
Rule 5. Multimodal.
Single treatments almost always fail. You must combine physical therapy, psychological support, and pharmacology.
And Rule 6. Restraint.
No long-term oral steroids. No opioids without a dedicated pain team on board. And absolutely no surgery unless specific, strict criteria like finding Hunner's lesions or a positive spermatic block are met.
Leave us with a final thought to chew on before we wrap up.
The guidelines end with a really interesting look to the future. Right now, we treat syndromes, which are essentially just crude buckets of symptoms. The future lies in deep biomarkers and genetic subtyping. We need to eventually stop treating bladder pain and start treating the specific molecular mechanism. But until we get there, remember the most important lesson. You aren't just treating an isolated organ in a jar. You are treating a whole person who has a profoundly sensitized nervous system.
A sensitized nervous system. That is a powerful paradigm shift to end on. Thank you so much for breaking this all down.
Thank you for having me. That's a complex topic, but so important to get right.
And thank you to our listeners. Good luck on the boards. Stick to the guidelines, avoid the traps, and you've absolutely got this. See you on the next deep dive.